It's my pleasure to introduce Dr. Lori Bruce. I had the pleasure of meeting her at the American Society for Bioethics and Humanities, and she is an incredible professional and leader in bioethics, and also just has this amazing aura about herself. So I'm very happy to have her here to talk to the Harborview Medical Center community. I'm a social worker here at Harborview Medical Center and on the Bioethics Committee, and I'm going to be introducing Lori Bruce. So, Lori Bruce has her doctorate in bioethics and a master's in bioethics and a master's of arts and her Hec C credentials, and is the associate director at Yale Interdisciplinary Center for Bioethics. She is a key researcher at Oxford Nuss Center for Neuroethics and Society, founder and chair of the Community Bioethics Forum at Yale School of Medicine, and affiliated faculty at the Solomon Center for Health Law Policy at Yale Law School. She is the co-director of Connecticut's Ethics Chairpersons Meeting Group, comprised of leaders of hospital ethics committees across the state. She has served on pediatric and adult ethics committees at Harvard and Yale for over 15 years, including having co-directed the Adult Ethics Committee at Yale New Haven Hospital for 3 years. She is on the board of editors at the J Law Medicine and Journal of Human Technology Relations. Her work includes ethics of psychedelics, as well as ethical dimensions of bodily autonomy in clinical practice, law, and popular culture. Her work is often centered in amplifying the voices and values of community members in health policies, including work on infant abandonment and confidential supported birth. She teaches courses in ethical policymaking, which are informed by her legislative successes at the state and federal levels. And she directs the Yale's Summer Institute in Bioethics. Her work has been covered by media outlets, including NBC Nightly News, The New York Times, CNN, Time Magazine, and her doctorate in bioethics is from the Stritch School of Medicine at Loyola Chicago. Also has an MS in bioimaging from Boston University School of Medicine and BS in Information and Decision Systems at Carnegie Mellon University. Without further ado, again, this is going to be an hour with Dr. Lori Bruce. Thank you so much.
Thank you, Lena, for that warm welcome.
Yeah.
I'm so happy to be here with all of you today. Okay, let's see if these. Okay, going to start screen sharing. Okay, can everyone see that?
Yes, that looks great.
Okay, wonderful. Thank you, Lena, and I'm delighted to be here today, and I'm grateful for this invitation to connect about hopes and complexities with respect to ethics and ethical policymaking. So we talked about what we're going to talk about. I'm a bioethicist, and I've also, unlike most bioethicists, studied policy analysis. My work is highly interdisciplinary. I often partner with legislators and other policymakers and stakeholders, and often with physicians and nurses and psychologists and community members. I've covered a lot of different topics over the past 30 years in ethics, but the consistent themes running through my work often relate to my wish to reduce harms and to increase goodness or create beneficence within health policy and within clinical encounters. I consider myself an accidental bioethicist and certainly an accidental academic. I honestly just kept taking courses, wanting to understand how we as a society, but also as individuals, could employ various frameworks and collaborate together to make this world a little bit gentler and a little bit kinder. So I just kind of ended up becoming a bioethicist and becoming an academic. And I'm quite compelled to instigate change in response to some of our most pressing societal and health-related challenges. And so today we'll be talking about some of those complex challenges and how we may collaborate together across disciplines. So 3 decades ago, I got my start in hospitals and within medicine as an outsider. I was a rape crisis counselor, and I was not employed by the hospital, but I was working within hospitals. And this was long before my days as a bioethicist. But I saw all sorts of good and helpful actions within academic health centers. And I also saw many ethical problems, such as practices that reduced a patient's ability to make decisions for themselves. Their autonomy was impacted. I saw practices and policies that contributed to their fears instead of reducing them. I also saw how some actions could reduce the risk of future trauma, but those practices weren't always consistently implemented across clinical encounters. So I grew to understand that these factors are all ethics and could be improved with ethical deliberation. But so what are we talking about today? What is bioethics, right? Bioethics is a field of inquiry. It's a way of examining and considering moral tensions within medicine and healthcare and other fields. Modern bioethics is a movement that rose up in the late 1960s. It was on the heels of the civil rights movement. And ethics seeks to examine what should we do? What ought we do when we're facing a moral dilemma? Ethics often considers how people should live and might examine what it means to be good or bad, or what principles and theories and frameworks should guide ethical decision making. Ethics seeks to understand moral judgments and considers rights and obligations and the impact of actions on others. And so part of what we think about is how can we help all of our patients and family members and our clinical students and our coworkers live more according to their values, while also hopefully allowing others to live by theirs as well. Modern bioethics was beginning at a time when birth control was just becoming widely accessible. Married women were going to their ministers and they were asking them if it was okay, was it permissible to have some control over the timing of their births? And so the role of sorting through these kinds of moral questions within medicine initially fell to ministers and to chaplains. And for the first time, medical technology was becoming good enough to actually prolong life in ways that we had never done before. Here we see the Engstrom ER300. This is one of the original ventilators. I don't know if any of you have ever seen this particular model before, but back then, we know that these ventilators were not necessarily prolonging life in a meaningful way. Family members largely didn't want their loved ones to be hooked up to machines that wouldn't help them ever recover or even regain consciousness. But back then, physicians didn't want to abandon their patients and perceived for the first time that perhaps taking away measures may feel to them like abandonment. And so there was this conflict between families and clinicians, and modern bioethics was rising up to help patients and families gain some control over these kinds of cases. And bioethics was also helping us to find new vocabulary to express these kinds of interests and questions. Within bioethics, within modern medicine, competent patients, of course, get to choose what happens to their body. Autonomy means self-rule. So as you can see, modern bioethics got its start from being responsive to new technologies, to murky and confusing societal challenges, to shifting cultural dynamics, and to laws and policies that weren't reflective of or necessarily supportive of those who were impacted. And when we consider where we are today and what's happening in our world, We're aware of how societal values and views and structures that control them continue to shift over time. Recently, we've seen a new set of federal policy initiatives that are coming out at a pace that we're not used to. We're seeing funding cuts that were unexpected. We're seeing extensive cuts to medical research and deregulation of all sorts of infrastructures that historically have had pivotal roles for how we function and how medicine and healthcare function. And so it is believed that reverberations of these changes will be felt for many years to come, and perhaps may even be testing our nation's resiliency, testing our ability to process and respond to change and disruption, and having some kinds of impacts on how we care for our patients. Bioethics continues today to try to promote good and to promote autonomous good decision-making, to resolve conflicts, to promote flourishing. We consider novel approaches to ethical policy making today in our talk together. So when we think about policies, we're thinking about something that does something to get something. All policies need to do certain actions to get certain results. But when we consider the paradigm of ethical decision-making, we want to add some more layers. We want to move past just the doing and the getting. We wish to explicitly identify the values we wish to guide our policy. We then may also wish to identify different sets of data, communities, groups, documents, other policies, and other places to promote collaboration and inclusion and transparency. And we know, of course, that I tell my students many times that good bioethics relies not only on community, but it relies on good data. So we have to really know what's going on and what's happening in order to then be able to say, what ought we do? What should we do? There are already forms of community inclusion within healthcare. And part of the goals of such collaborations are to try to stem the conflict, which may not, that occurs sometimes between patients and families and hospital systems, because sometimes our policies don't mesh with the views and the values of clinicians, of patients, of families. And so there are ways to solicit views and values of community members and certainly of clinicians to try and amplify those values within policy. But we all know that when we are asked to participate in various methods of policymaking, whether it's within our institution or more broadly within local, state, or federal law and regulation, it's hard because we all have other jobs. And so we have very minimal time, and very few of us have been trained in policy analysis skills. So there are ways that we pick and choose and try to do the best we can to gain a broader sense of how our policies will impact those who are subject to them. And so community members sometimes may serve on hospital ethics committees. And I believe that you do have some community members on your committee. Hospitals may also have an Office of Patient Experience comprised sometimes of former patients who are asked to provide their perspectives. We also often, increasingly, are including community health workers within hospital systems. And these are folks who share the same lived experience as those shared by some of our patient populations. But it's tricky, right? It's really tricky to find ways to be more thoughtful about policymaking because we don't have a lot of time for it. And we haven't really generally been trained on ethical policymaking. So one of the models that I often use in my work, whether it's with legislators or whether it's within an institution, is to not immediately jump into the doing and the getting when we're designing a policy or a law, but to take a breather and to think about first, not my values or your values, but which values do we wish to underscore and scaffold the policy or program that we want to design or redesign? And what values should that program emphasize? And based upon this list, then we think about who and what we ought to include in various aspects of that program or policy or law design. And then that helps us to keep bouncing back and forth among these four categories to think, okay, well, if that's who we're including, that's going to sometimes shift what we really want to get out of this policy or how we want to measure our success criteria, or indeed the actual actions that we're taking within a policy may indeed shift as well over time. And this is this kind of logic model, this process to policy making is something that I often spend at least a couple months teaching, but we're just getting a broad, quick exposure to it today. And to complement my VIDG model, which is based on these traditional logic models, this traditional approach to policy analysis, as a complement, I often rely on the paradigm of community ethics committees. Way back when I first got my start in bioethics, I was pulled into bioethics by Carol Powers. She had been, she had decided after a rather traumatic experience within healthcare herself, based upon the death of her very young son who suffered in the NICU for several months, she decided to create a community ethics paradigm. And she worked with Christine Mitchell and other good folks at the Harvard teaching hospitals through the ethics fellowship that they offer. And she created this very novel paradigm to help amplify the voices and values of community members within institutional policy. And since then, her model has grown. And it also does advise for various state and sometimes federal laws as well. So I spent a number of years with Carol, and then when I came to Yale, I created the second community ethics committee, which we call the Yale Bioethics Forum. But central to all those discussions, because as I mentioned, I was a reluctant bioethicist. I really never planned on becoming a bioethicist. I didn't know what that really meant. But when I thought of the words about, being asked to be a part of Carol's group, being asked to help make policies more ethical, I kept pushing them and saying, well, whose ethics matters to you, right? How do you navigate that? How do you decide whose values to prioritize? Because they can often clash. And so this began a decades-long friendship and wonderful relationship with Carol Powers, who I value so dearly. And her committee has examined many different topics you see here. All of her reports are available at the link you see at the bottom, and I will share my slides if you'd like to access her reports. My committee has also looked at a number of topics, including infant abandonment, unconsented exams, hospice at home for children with developmental disabilities. So we've helped to revise a number of state laws and some federal work, and we helped to create some FAQs for brain death from the Neurocritical Care Society. And some of our other results include reports for Obama's Presidential Commission on Bioethics, and as Lena knows, a number of presentations at the annual ASBH Bioethics Conference. So today I thought we would spend a little bit of time talking about this policy that I didn't really plan on examining, but I ended up examining. And what happened was I was having coffee with a Connecticut state legislator who had reached out to me. He said, hey, let's meet up for coffee because I'm interested in your thoughts on death with dignity or physician-assisted suicide. And so offhand, he said, hey, other states are passing these laws to require explicit consent. And he said it kind of like that, explicit consent for pelvic exams. And he said, is this a problem? Like, what's going on with that? Is it ethical? Should we have that too? And so I was surprised to hear him mention it, partly because I had just agreed to a journal to write an article on this subject, because I was a bit skeptical of this, because I had heard claims from time to time, but to me, I didn't know if it was just some anecdotal things that happened, and I was curious. And so I started really digging into this topic. And so when we're referring to unconsented pelvic exams within hospitals, they are at the time, they were perceived to occur most often by medical students as extra exams for training purposes and not for the benefit of the patient. To facilitate training, teaching hospitals were permitting medical students and other learners to practice on anesthetized or sedated patients without the patient's knowledge or consent. It was most often occurring when a patient was in the hospital for a gynecological procedure, but also known to occur under other conditions, like a patient being in the hospital for a laparoscopic stomach surgery. Now, whenever I end up studying various policies, people all over the place approach me and they say, "Hey, what are you studying? What are you looking at now, Lori?" You always end up looking at the craziest topics, and so they're always curious. And with this topic, it's really one of the only ones that I've examined where community members and legislators were, frankly, quite unanimous in being very concerned at the thoughts of these exams occurring without consent. And so there was also confusion from legislators about whether or not this was really a problem, because some folks within hospital leadership across the nation, because I was examining this nationwide and globally, would deny the existence of the practice. They would say it's not happening. And so we agreed that my community ethics committee would look at the nature of these exams. And so just to give you a little bit of background, the practice of unconsented sensitive exams had been condemned by hundreds of physicians and ethicists and legal scholars, deans of medical schools, prominent medical associations like ACOG and AMA, lots of medical and nursing associations. Thousands and thousands of medical students were condemning the practice, saying that it was happening. And legislators and many others were speaking out against this, saying, this should not happen. So there was this long history since the 1980s of thousands and thousands coming forward saying, this really needs to stop. And indeed, it would not be surprising to you that patients expect explicit consent, and yet the actual practice was that patients were not being asked. And this just cites two surveys in the second box here with the yellow bars. But since I've created this slide, there have been several other surveys that have found the same findings, that indeed this was happening. And many prominent bioethicists did indeed say, and deans of medical schools did say, yep, we still see this happening. Medical students are still coming to me saying, I'm being told to participate in these unconsented pelvic and prostate exams, and it doesn't feel good to me. I don't like doing a procedure on someone without their consent, especially when it comes to a sensitive area. Dr. Stern went for a prostate exam after having recovered, having finished his treatment for cancer care. And before that diagnostic exam by his physician, he was approached by a medical student who said, "Hey, Dr. Stern, can I do an extra exam on you, so that I can be trained?" And Dr. Stern just wasn't feeling like it that day, and he said, "No, I'm going to take a pass. I want you to be trained." I'm sure he had said, but he didn't want to participate in the extra training exam that day, and that's his right. And then what happened was the physician came in and did the exam, and then turned to the medical student, and Dr. Stern was awake and said to the medical student, go ahead, it's your turn to do the training exam. And the medical student did indeed perform that training exam. And Dr. Stern wrote about this in Men's Health magazine because he was really uncomfortable with what happened. And he said it was terrible. I was awake and I had said no. I expressly denied the student's request. A patient shouldn't have to meet the needs of the provider. He needs to be asked. And so this was kind of a landmark article, as you can imagine. Dr. Stern's intentions were to help people outside of medicine learn what might happen to them within some of their exams. And I must state emphatically that we know many physicians and many teaching hospitals don't train in this way and do explicitly ask for consent. However, that wonderfully impeccable process of asking for explicit consent had not been consistent across the United States. And so Sean Barnes also wrote about his experience when he was a medical student, and he talked about his shame that he felt when he partook in conducting unconsented sensitive exams for the purposes of his training. And his paper was published in the ACOG journal. And then as kind of a parallel effort, I ended up writing up a history of the issue, including the ethical challenges. And I found that for over 35 years, as I mentioned, all of these different parties had been speaking up against the practice, and yet the practice continued in many teaching hospitals. So, why do we even need consent, right? So when we think about, why consent matters, it improves the physician-patient relationship because transparency promotes trust. Dismissing repeated calls for change compromises trust. And consent protects medical students and other learners from moral distress and moral erosion. And of course, at the heart of all of this, as we know, that patients are the rights holders of their bodies. So I had mentioned that my community bioethics forum was going to look at this topic, and some of them did indeed endorse having received unconsented sensitive exams. And that endorsement was based upon their experience living in many different states across the United States. And part of what they said is that they felt that they should have had the right to decide what happens to their body. And one of the main points that they said was that, a lot of the clinicians said, oh, this, you don't have to be worried about this. I view your pelvic region just like it's any other body part. I'm a professional. And they understood that. And they, believed them in that they were, acting professionally when they were giving these exams. However, patients don't view these regions as if they're any other body part. These body parts require a particular level of disclosure and consent. So one of the frames that might be helpful and is consistently helpful for me when I write policies and when I conduct ethics consults is to not think about, is to instead of just relying on our principles, instead of just relying on a lot of the ethical theories that we all have studied, but to think about it in terms of the method that Elizabeth Lanphier and Uche Anani have devised, which is trauma-informed clinical ethics. And they propose a wonderful framework that considers what is going on for a patient and their family, as opposed to what's wrong with them, right? As opposed to saying, I need to get my training done. What's wrong with them that they care so much about consent? Or, there's, why doesn't the patient take their medicine? They're non-compliant, right? To kind of try to flip the script on that. So that might be a helpful framework for you all to explore in your work. But again, within the CBF, what they found was that they spoke of their profound respect of the medical community, and many, I think all of them, had participated in extra exams from medical students during the course of their medical care. But they were really very uncomfortable with these unconsented exams that they had endured. And so I recognized at that point that based upon their experience in many different cities across the US, that this small group of 20 had experienced unconsented sensitive exams. But again, that's like 20 people, right? And so what I have done within this model of community ethics is to extend the paradigm, and then after having a local deliberation, is to write a national survey and then ask others what they think about it. And there was other evidence as well. There were several thousand medical students over, I think it's now 6 national surveys that all indeed endorsed having had participated in these exams. And all sorts of other evidence was being gathered about these unconsented exams. And yet some teaching hospitals remained entrenched in their positions or denied the practice despite medical student testimony, stating that consent was already acquired or the medical students must have been confused. But again, this drills back to this idea of whose voice matters, whose voice is credible, and whose voice has power, right? Who can really instigate change here? So as I mentioned, I did design a national survey as a follow-up to my local data, and I did that through, there's this wonderful book by Cornelius and Harrington about a social justice approach to survey design. And my national survey did find that these exams were received by, when you extrapolate, by millions of US residents, and that they were reported slightly more frequently by male respondents than female respondents. And tragically, there was quite a bit of racial disparity in the outcomes, since unconsented sensitive exams were reported nearly 4 times more often by our Black respondents than our white respondents. So sometime after my survey was published, it did get picked up by NBC Nightly News. They contacted me and they said, they wanted to cover this topic. And I said, okay, I'll send you all of my reports and my data and my papers. And I said, but you don't want to interview me. You want to interview an OBGYN who has implemented explicit consent. That's who you want to hear from. And so indeed, if you watch this story, they interviewed Julie Kaur, and shortly after that story broke, I was contacted by federal legislators on the Hill who said, we want this practice to stop now. What do you suggest we do in order to stop it? I know you've been working with many, many states to pass state laws, and I let them know that sometimes those were effective and often they weren't. So they said, what do you think we should do? And I said, why don't we try to tie it to CMS funding, such that if there was not compliance, I was just kind of like, maybe we'll do that. And indeed, they enacted that. And so about 5 weeks after my phone conversations with folks on the Hill, this letter came out from the Department of Health and Human Services saying that you have to have explicit consent for pelvic and prostate exams. And so when he announced the policy change, he stated his awareness of the media reports and medical and scientific literature, highlighting instances where patients have been subjected to sensitive exams without proper prior informed consent. And so he said, of course, exams always require consent. And so he reinforced the federal guidelines. And so, what can we take away from this? That there is, sometimes this disconnect between teaching hospitals' entrenched beliefs and assumptions and the values of many clinicians and professional associations and students and others. And there's sometimes what happens is we end up prioritizing efficiency of practice and tradition over patients' rights. So I can talk more about this, but I thought, part of what was so critical here were these, what else was happening in the room, because this isn't just about patients. Medical students were having moral distress from having participated in these exams. 94% of medical students found that these unconsented exams were unethical, but only 5% refused to participate in them. And what we know from the literature on moral distress is when moral distress is continues, that sometimes it can turn into moral erosion, where the values that we hold dear shift, and we don't hold those values dear anymore. And Ari Eisenstadt studied this, and he examined medical students' belief in the importance of informed consent. And he surveyed them before and after their clerkship rotations. And after all of the clerkship rotations, their perceptions of the importance of informed consent remained steady, except for the OB/GYN clerkship, after which their perception of the importance of consent dropped. And it dropped not just for procedures related to obstetrics and gynecology, but it dropped for all procedures. And so that became a landmark article that was cited quite a bit. And this all loops us back to this idea that, of course, patients do have the right to refuse training exams. And so some of us think about, how this training sometimes may take precedence over patients' rights to bodily autonomy, and how we can sort through this and support our learners. And we know that unconsented sensitive exams are not the only example of where our hospital policies or practices may not align with the views and values that we all hold dear. And we know that many hospitals are indeed stalwart advocates of patients' rights and early adopters of explicit consent. And so there is certainly a way through this. I have been heartened by how fast change can indeed happen, both within hospitals and within federal regulations, when we take the time to find out what's really going on, as opposed to what our perceptions are of what's going on. And I truly think that when we think about this issue of unconsented exams, I think there really hadn't been the understanding of what was really going on by those who were in power. And so once these inconsistent practices across hospital systems came to light, then the change occurred quite quickly. So unconsented exams are just one of many, many policies that I have studied and that I have changed. Another relates to the health and welfare of births in crisis and pregnant people and infants who are at risk of birthing alone outside of a hospital without any medical care. Because, and as we know, the number of births in crisis is likely rising across the United States right now. And many legislators in at least 35 to 40 states have been approached in recent years by advocates who would like there to be more options to be able to surrender infants when there has been a pregnancy in crisis that may not have been intended, and to give that parent in crisis an additional means of surrendering their infant. Every state has a safe haven law, which is this legal means for a parent to surrender an infant when they're unable to care for it themselves. And these laws are increasingly being used. And part of the ways that they are changing quite rapidly is the idea of offering not just the face-to-face surrender, which is safe and very much preferred by parents and certainly preferred by healthcare practitioners, but to also offer the option of a black metal box, which purports to offer anonymity, so that someone could deposit their infant if they are under duress and feel they cannot care for it. But we are aware, when we examine the data, that 80% of those who surrender cite financial concerns as one of the top reasons that they feel they are forced to relinquish their children. And they state that even a few $1,000s or even enough to afford a car seat would have made the difference between helping them to keep their child as opposed to having to relinquish. Many people who are in this position are not aware of their options. Knowing options is especially important because adoption scholar Gretchen Sisson tells us that the grief of relinquishing a child is associated with unrelenting lifelong trauma and grief. And when we consider how these boxes are implemented, you notice what you don't see around the boxes are any sort of signs that say you have options. You could go to a hospital for crisis counseling and options and medical care. And so the rollout of these boxes caused me to go back in time. And I have examined what it was like for parents to relinquish their children during a time that we have studied. Because we haven't really studied modern infant abandonment. We haven't really studied the views and values and interests of these parents. There are these blanket assumptions that are made about them. But when we go back in time, we can often find helpful clues about how we ought to move forward today. So sometimes a person abandoning or relinquishing their child, they would leave some kind of a memento because they wanted a way to prove their identity and their connection so that they could come back and reclaim their child as soon as they were able. The choice of these objects often has strong symbolic power that would help to showcase the unique connection between the parent and child, such as a lock and its key, or a wish for a safe and secure future. And in this case, one parent said that they left a padlock so that if circumstances would ever change, they could come back for her and she would be secure. Or they said, I hope to unlock her heart. Or she, tiny padlock in grown hand, could come and find me. And so other artifacts that are now on display at foundling museums in London and in Italy show other kinds of tokens, such as coins that were cut in half. And one was pinned onto the infant's clothes at the moment of relinquishment, and the other was strung around the parent's neck, close to their heart, until they were able to come back and reclaim their child. Some of these mementos you can see were painstakingly created. This, to me, looks like a heart with outstretched arms with very detailed beadwork. And so these looking into and having ended up studying infant abandonment for nearly 15 years now, I did recently write an article about these baby boxes, these infant abandonment devices, and that was published in Pediatrics to help inform pediatricians of what's happening. We also wrote a letter that was signed by 100 colleagues, physicians and ethicists and adoption scholars and community members and members of Indigenous communities, urging regulation over these devices because right now these boxes have no federal oversight. They also have very minimal state oversight, and no one is regulating the alarms or electrical device components and the videos that are so critical to being able to inform someone when they receive an infant in this condition. ABC News has a story about this, and I've examined other policies from other countries that are much more effective and preferred by parents to help them in this moment of crisis. And so I did write the very first act of confidential birth that was ever presented here in the US. It is a policy that has been enacted in 11 other countries to great success. It is rooted on what's going on for the family, the pregnant person and the infant, what's going on for them as opposed to what's wrong with them. It's more rooted in collaboration and inclusivity. And so I am working with hospitals and legislators across the US to try to offer what we call confidential birth. And I can't get too much into the weeds on any of these topics. I could talk for hours on them, but I did want to state that sometimes the work that we do, at least to me, can feel quite precarious. Sometimes it feels like we're the only person that is maybe going to be able to kind of carry this load. But what I teach my students and what is so critical to me about bioethics is that this idea of us carrying a heavy load is a fallacy, because good bioethics is all about community. And I often reach out to bioethicists all over the world to ask them how they solve these tough problems. And we've been able to really make great inroads into creating more collaborative, empathic laws and policies across the globe. And so I hope that some of the inroads and the methods that I've discussed today might be a helpful starting point for you. You may want to consider joining some coalitions or meta coalitions, which are coalitions of coalitions. You may want to consider grassroots efforts. In this day and age, we may indeed feel the need to shore up ethical safeguards within other layers of oversight for those that are shifting in ways we may not have expected, to examine how we may be able to buffer up our institutional policies, how we may be able to extend out some association guidelines or state or local laws. And in closing, I just wanted to say that, advocacy, I suppose, can sometimes feel quite frenetic, and you don't know what will move the needle. But policy theory does encourage us to keep going and to try different methods. And through public communications and coalition building and a search to identify compelling voices within public discourse, our work does indeed sometimes manifest in meaningful policy change. And in this case, it should promote trust at the bedside. So I always close with an image of my summer institute in bioethics. And I offer virtual short courses called my Foundations in Bioethics program. And I also offer longer courses that are in residence in June and July. They are very, very global. They're very collaborative. We talk about scores and scores of different bioethics topics and theories, and I always can find scholarship money. So if you have a colleague who is looking for a short virtual course, or if you have a student or colleague who's looking for an in-person immersion, please don't hesitate to send them my way. So thank you all for your time today. I encourage you to stay in touch, and I appreciate your time and attention today.